Hello students, I'm giving you the lecture for week 3, chapters 15 and 16. I got the email today from Linda about some concerns. First of all was requesting a checklist for paperwork for clinical. I sent that out in announcements a little over a week ago. So if there's still confusion after that checklist or what I sent you, then we will discuss it when I'm back next week. There were concerns about not being tested on the material in the lecture, so we will just have to discuss that issue when I get back. And then students were requesting another lab day, so we will talk about that also when I get back. I am planning on OB clinicals on Monday, the 21st, I think the date is. I'm not really sure. I don't have my calendar here. So not this week, but next week, Monday. So people coming to CMC for NICU and OB, please, whoever's scheduled for those days, please plan on attending. So I'm just going to proceed right now with the lecture from last week. Get that recorded and up on Moodle, and then here in a little while I'll put the lecture on, the recorded lecture on for this week. Also, when it comes to the content for the last exam, we will still review that content, and then we'll discuss as a class what to do about that exam. I do have a couple of ideas to present to y'all. So anyways, I would like to continue to have exam 2, which is on the schedule for this weekend. I'm going to send out an announcement along with this recording for your opinions on whether we need to postpone that exam, or whether you feel from your readings and from my lecture, recorded lecture, whether you feel you are prepared for that exam. Okay? So it's all going to be good. We will take care of things, and I will not let you down again. Okay? So we'll get this taken care of. So chapter 15, caring for the postpartum family. Oops, let me go to big screen. So here are your learning outcomes. Oh crap, for the chapter. I don't know how to make this stop. Anyways, so the 4th trimester, sorry. The 4th trimester, so as we reviewed earlier, the 4th trimester is after the placenta is delivered. So the 4th trimester is after childbirth, and it usually encompasses about 6 weeks. So basically her recovery from the birth. They consider that the 4th trimester. Okay. The one things we're concerned about in the 4th trimester, immediately and later after the woman goes home, is hemorrhage. So that's a big thing for pregnant and recently delivered women, as we want to make sure that we identify hemorrhage, and that we also educate the woman, especially after going home. If she thinks that she's not going to have a hemorrhage when she goes home, and indeed she does go home and starts bleeding heavier than normal, she may not question that, and she may get herself into a little bit of trouble. So we need to educate women before they're discharged on what is the appropriate amount of bleeding. And then, of course, on her care, her baby's care, and then making sure that they have the support that they need. So you've heard of healthy people So 2020, here is the data that they want to achieve going forward. So this is just a little bit of information for you. You won't be tested on this. But it would be good, especially in areas where you're working, that you do look up what Healthy People 2000 or 2020 or whatever's most recent. What's the expectation of health outcomes for our population? So, oh, sorry. The Health Protection Act of 1996 was, and this is also something that you're not going to be tested on, but just for your information, there was a lot of changes in insurance coverage for pregnant women and recently delivered women, as well as fathers of babies. So usually insurances wouldn't cover a long stay at the hospital. And we were realizing that outcomes when we discharged these mom and babes early. So this change occurred, and giving mothers 24 hours after delivery coverage to stay, and then up to 96 hours for C-section women. So the things we're concerned about, of course, is safety for the mother and infant. A lot of work has been done to prevent infant abductions. Even before the little nugget alarms that we put on the babies that lock all the doors and the alarms go off when someone tries to take a baby out of the unit, there was a lot of work put into different protocols to ensure infant safety from abductions, and also mixing up of babies. So, we used to have nurseries where we put all the babies in there so we could let mom rest and recover, and there were some issues of, cases where wrong babies were taken to wrong mothers. So we put the security nugget on the baby. We check the ID bands. In our facility, babies are not taken from mother's room or from mothers, and unless there's a medical necessity. So if that was to occur, we would return the baby. We would check the baby's ID band with the mother's ID band to ensure that we have brung the correct baby. And then we also educate the family on these safety measures, in addition to safe sleeping, which is on your back, safe cribs, choking, and the use of the bulb syringe, which is that little sucky device that we, when babies spit up or get stuff caught in the back of their throat, we can suck that out. So safe temperatures, safe dressing, safe bathing, and just all the safety measures that we are concerned about for our babies. So when the mother has had her baby, her vital signs, of course, are temperature, pulse rate, blood pressure, respiratory rate. We assess pain every time. And then so immediately after her vaginal delivery, there's a 2 to 3 hour recovery period in the labor department. And if she is stable and that recovery period goes well, then we transfer her to mother baby. But in the labor room after vaginal delivery, so we check the vital signs every 15 minutes times 4, every 30 minutes times 2, every hour times 1, and we continue every hour times 1 if we are a little bit concerned. However, if we're a little bit concerned, then we may not be waiting a whole hour to check vital signs, depending on her level of stability. And then after that initial recovery, her vital signs are Q8 hours. We can always do vital signs early. A nurse's critical thinking, her assessments of her mom, if she is thinking that mom is not doing so well, then the nurse will check these vital signs more frequently. And a lot of signs an anticipation of further deterioration can be detected with simply checking vital signs. So when in doubt, just check vital signs. But for C-sections, it's a pretty similar recovery initially, but then after the initial recovery, then we do Q4-hour vital signs for 24 hours, and then we will change to Q 8 hours. Now, in addition to vital signs, we're checking fundus. So usually the fundus is anywhere from the umbilicus down. So, it could be halfway between the umbilicus and the symphysis pubis, or it can be at the umbilicus. I have some norms here for you. They do not have to absolutely follow these norms. The important thing to remember here is her umbilicus at the U or below, and is it firm? Is it midline? In other words, are you feeling it in the center of her belly? Are you feeling it off to the right or off to the left? And is it firm or is it boggy? What is her bleeding like? Does her bleeding seem normal? Does it seem a little heavy? So even if we have an umbilicus that is at the U or below, umbilicus or below, if her lochia is not normal, then we're not in a normal situation, okay? She could have a firm uterus or fundus that is at the U or umbilicus or below, and she could be hemorrhaging, okay? So that would tell us that maybe it might not necessarily be from the uterine lining. It might be from lacerations that were not detected. It could be from the uterus, maybe a retained placenta. Maybe there is a big clot in there that is kind of making the uterus feel firm. But anyways, we need to assess all these things and put all the pieces together to determine whether or not this woman is stable. And if it's above the umbilicus, now this is where you need to use your critical thinking. Is it firm above the umbilicus? How far is it above the umbilicus? Is her bleeding normal? So on occasions you might find a uterus that is 1 to 2 centimeters or 1 to 2 finger breadths above the umbilicus. Her uterus is firm. You're not expelling any clots with your massage. Her lochia is normal. Her vital signs are stable. Then maybe we will just watch her a little more frequently to just make sure that she continues to stay stable, okay? But if it's above the umbilicus and she has a boggy uterus and she's bleeding heavy, like all those things are not normal. Now, if it's to the right or left, that is indicative of maybe a full bladder, and a full bladder will compromise contractility of the uterus. So we will want to get that woman to void and then reassess and make sure that the uterus or fundus has come midline. So our perineal assessment is, if she does not have an episiotomy or laceration. So the episiotomy is when the obstetrician cuts into the perineum to make a little more room, or a laceration is he did not cut and she tore. When the baby came through, her perineum tore. So we will want to make sure we continue to assess that. And you can use your Rita. Rita is a common mnemonic for any type of laceration or incision to check for its stability. So Rita stands for redness, edema, ecchymosis, drainage or discharge, and then the approximation of the episiotomy or laceration or incision. So are the edges of the incision, do they seem to be approximated, which is like touching and together, or do they seem to be gaping open? Okay, so we will be checking that. That also can be used for if you have a C-section incision, but many times there's a bandage over it. We don't remove the bandage to assess the incision unless there is like copious amounts of drainage that are seeping through the incision, and then we do need to get that dressing off and check it. The other thing about the perineal assessment is we will check for hemorrhoids. And also just edema. So she may not have an episiotomy or laceration, but she may be extremely swollen. I have seen labias that were so swollen I almost couldn't recognize them. And so we want to also assure that this edema is edema and not a hematoma forming, which will look purple, it will be taut, it will look like a big bruise growing, and that is significant for hemorrhage because a woman can lose a lot of blood in her perineal tissues. So what we do for hemorrhoids and or swelling of the labia and incisions, lacerations, episiotomies of the labia is we provide ice packs. We have special ice packs that are kind of an ice pack perineal pad. We have ointments, we have witch hazel pads, which we also use for perineal discomfort, not necessarily just hemorrhoids. And then frozen tea peri pads, which we don't have, but we could suggest that for the woman at home. The Sims position is, just her laying on her side with her leg kind of flipped over so that you can get a really good assessment of her perineum. Okay, so I just want you to know what the Sims position is, and that's what they recommend. So when I check a woman's perineum, I don't always have her flip over like that unless I'm concerned about hemorrhoids or if she has a laceration that really extends towards her anus. But I just have her frog leg and do my assessment. And if I don't feel like I'm getting a good visualization, or if I need a further, more in-depth assessment, then I may flip her over into a Sims. Okay, so Bubble He is just a little mnemonic to help you remember specific postpartum related assessments. So when we do a postpartum assessment, we're doing a head to toe assessment. So we're gonna, assess level of consciousness. We're gonna assess neuro. We're gonna assess respirations, heart rate, bowel sounds, nausea, vomiting, voiding. Her musculoskeletal, like, is she able to get up and ambulate? Does she feel strength in her legs? Does she have her sensation back from her epidural? We're going to be checking for edema, palpating pulses, just a normal head-to-toe assessment. But the Bubble He is just a little mnemonic to guide you in a postpartum specific things to also include in your assessment. So the first B stands for breasts. Especially for the breastfeeding mom, we want to make sure that, we want to assess nipples for, are they flat, are they inverted, are they everted, in other words, poking out. So that will give us an idea of, the problems she may have with breastfeeding. We want to assess if her breast feels soft, if they are starting to feel firm and full, to just to indicate whether or not her milk is coming in yet. And then for the non-breastfeeding mom, we will ask about these things as well, but we're going to really be instructing mom of comfort measures because her milk will come in, she will feel engorged, it will be uncomfortable. We want to let these moms know, please don't express any milk to relieve that discomfort because that's just going to signal your body to reproduce that milk. So, cool compresses will help, cabbage leaves and things like that. So we want to make sure we assess for warmth, cool sensation, redness, cracked bleeding nipples. That would tell us that baby is not latching on well. So when a woman breastfeeds, sometimes she's a little sore. The nipple's kind of getting in shape for breastfeeding, but she shouldn't be having so much pain that it's excruciating. She shouldn't be having any cracking, bleeding, blistering, or bruising. Those are indications of poor latch, and we have to address that. So then we move on to the U, which is the uterus. We've already talked about our assessment of our uterus. The second B is the bladder. Is she voiding? Is she voiding completely? Is she unable to void? Do we need to maybe straight cath her? We can palpate her bladder, and then we can assess urine if we're able to see it. Now, I don't say to a woman, hey, when you go pee, leave it in a hat in the commode so I can go look at it. But if I'm concerned, then yes, I will. Excuse me. The third B is the bowel. When was her last bowel movement? Typically, women who deliver may not even have a bowel movement before they're discharged. And that's okay as long as they're not having feelings of gassiness, bloating, constipation, or that they're not having any nausea or vomiting, okay? So we'll ask, are you passing flatus? We'll listen to bowel sounds. We'll assess, especially C-section moms that do sometimes, not frequently and not always, but occasionally we will assess a mom who was a C-section who's starting to get distended from gas. And you can palpate her abdomen and almost see that distension. So we will need to treat her, do some things, maybe give her a stimulant of some sort, laxative, or a suppository or something to help relieve her gas. And then lochia, we've already discussed lochia. The episiotomy, we've already discussed that. So some other really significant things with postpartum moms. So as we are learning, deep vein thrombosis or DVTs they're at risk for those just because of the extra blood volume with the pregnancy, and she's not going to be running a marathon right after she delivers, so there's a lot of kind of bed rest and stuff like that. So we want to make sure we're assessing her lower extremities. I do not do a Homan sign on anybody ever because if she does have a clot, that puts her at risk for dislodging that clot. So I palpate her calves for pain with my palpation. If I feel warmth or see redness, if there's swelling, the woman may have varicosities. I assess the pedal pulses and sensation and all that kind of stuff. We want to make sure we assess mom's emotional status, bonding, baby blues, postpartum depression are common, and then we just want to make sure that she's bonding appropriately. So if she's not, that raises big flags and concerns, not necessarily because of something bad. Sometimes her lack of bonding with the baby could be, I have had encounters with moms, when I walked in the room, the baby's laying there crying and the mom's curled up in the fetal position on her bed and not doing anything. Sometimes these moms are just scared so bad and they have no idea what to do. They feel like totally powerless. And so it's not because there's a safety issue that we just need to work with this mom, okay? So discussing breastfeeding physiology. So postpartum progesterone and estrogen are hormones that are part of breastfeeding process. Progesterone stimulates the lobules, so those are the little grape-like clusters in the breast that produce milk. So progesterone stimulates the formation of those lobules. Estrogen, so from the lobules goes down into the ducts, and the ducts go to the nipple where the milk is taken by the baby. So estrogen takes part in the formation of those ducts and the growing of those ducts, the formation of milk secreting glands, and then just preparing the breast tissue for breastfeeding, okay? And then so, of course, breasts do not usually undergo any type of changes, swelling, pain, growth in any way, unless the woman's menstruating, unless she's pregnant, unless she's lactating, and then, of course, during the menopausal period. So here's just a diagram of the breast. So let me see. So here are these glands, which what we call look like grape-like clusters, and then the little tiny things inside these glands are called alveoli. Okay, here are the ducts that the milk comes through. Okay, here are the ducts, and then they come out the nipple. Okay. All right. So again, our breast assessment. We've went over this. So the milk doesn't just come in right away. Her breast will be soft for the first few days. So I don't typically go and palpate women's breasts every time I do an assessment. I sometimes just ask, do your breasts still feel soft, or are they starting to feel full or heavy? Okay. And then I do make sure that if the woman is experiencing any pain or problems with her nipples, that I am checking her nipples. Okay. Blood and dried milk. There might be a little blood on her nipples. That won't hurt the baby. Actually taking some breast milk and rubbing it around the nipples and the areola will help with those soreness and healing. Okay, so we've talked about the uterus. This is actually kind of like the physiology of what's going on with the uterus as it returns to normal pre-pregnant status. So the placenta is usually delivered within 15 minutes, actually usually delivered within 5 minutes, but it could take up to 30. Okay, uterine contractions continue after birth. They're called after pains, and that's what's, when her uterus contracts, that's what's constricting those vessels. Okay, and then we will do uterine palpation to help stimulate those contractions if we find a boggy uterus. So when the process of the uterus returning to a pre-pregnant state is called involution. Okay, and again, it's initiated by uterine contractions, which reduce blood flow, and then that blood flow, or lochia, is a combination of blood, serosa, and the cells that slough off the uterine lining, which specifically is the decidua basalis. Okay. And then a process of phagocytosis of the fibrous tissue of the uterus that were created to support this growing uterus occurs. And so that's just the physiology behind it all. And then usually by the end of 6 weeks, the woman's uterus is back to pre-pregnant size. Okay? Now, exfoliation. So involution is the process of the uterus healing and going back to pre-pregnant size. But right where the placenta was attached to the uterus, that's a little different process, because those vessels in the uterus that were with the placenta attached, or that were feeding the placenta, are actually a little bit bigger than the vessels throughout the rest of the uterus, because there's so much blood flow being going from the uterus to the placenta. So that healing process is called exfoliation. Okay, so at that site, those that tissue layer will slough off. Okay, and new tissue will be generated. Now, what we want to happen is for you to look at that uterus and not see any scarring where that placenta had been. And if we do have scarring, then the exfoliation process did not occur correctly, and that scarring will cause problems for future implantations of the placenta. Now, the placenta does not have to implant at the exact same spot as the previous placenta from the previous pregnancy. However, depending on the scarring, the size of the scarring, and how many pregnancies she's had that may have had problems with the exfoliation process, we could have a uterus that will not be very supportive of future implantations because of scarring. So we do not want the scarring to happen. So if it happens correctly, the exfoliation process, that uterus will be completely healed and be able to take another implantation of a placenta by the end of 6 weeks. Oops, So I said involution was the term that we said is to describe the normal process of a healing uterus to pre-pregnant size. So if it does not heal correctly, that term is called subinvolution. Okay. And here are some risk factors for a uterus that does not heal properly. Multiple births, hydramnios. So hydramnios is the term for too much amniotic fluid during the pregnancy, so overstretching of the uterine lining and muscles, prolonged or difficult labor, infections. So, wow, I had a misspelling there, analgesia. So these are some risk factors for a problem with the uterus healing and contracting and coming back to pre-pregnant size and decreasing bleeding. So we want to watch out for hemorrhage. We've already reviewed how to do uterine palpation. So our fundal assessment, again, review really quickly. So it should be at the umbilicus or below. It descends about 1 centimeter a day. So if you're on day 3 and it's not 3 centimeters below the umbilicus, but the uterus is firm, her bleeding is normal, her vital signs are stable, then okay. All right, so that's how our critical mind needs to determine whether that's normal or not. Okay, we look at all of our assessment parameters. But this is just a basic guideline of what, it's just a basic guideline, okay? All right. After pains, I've already said, are contractions of the uterus after delivery. That's needed for the process of involution. The more pregnancies the woman has, the more painful these after pains are, because the harder the uterus needs to work because it was overstretched. Because it was stretched multiple times because of multiple births. All right. So here are some comfort measures we can offer the woman. Ibuprofen with a normal vag delivery. Ibuprofen is usually the ticket for these gals, but there's some gals that have a little more intense pains, so we do provide them with narcotics if they need it. We want to assess the bladder. As I said, a full bladder will inhibit contractility of the uterus, so we want these women to void. We want a spontaneous void within 6 to 8 hours. However, usually at 4 hours, I'm pacing and want to do something. I don't like waiting 6 hours, especially if I have a woman who's having a bleeding issue. So we want to make sure we know when the first void is. If we need to, we might need to straight cath this woman, okay? She's going to be voiding a lot. Within the next couple of days, so she could void up to 3,000 cc's a day as she's excreting all this extra volume that she has produced during pregnancy. Okay, so these are the things that we're looking out for, that she has complete emptying. If she has incomplete emptying, then she's going to start getting distended. We're going to have problems with your uterine contractility. Okay. All right. So we can palpate the bladder, and we can do a straight cath if we need to, but usually it's not a typical problem. But we do want to make sure we're assessing for it. The bowels. So we do want to. Are you passing gas yet? Have you had a bowel movement yet? We want to educate the woman that she may not have a bowel movement before she goes home. We want to educate her on the signs of constipation, bloating, cramping, gas, and also, like, she will not have hunger. And if she does eat, and she's having constipation, she's getting backed up, she may start vomiting. Okay, so we want to make sure we assess for those things. We like to get these women up and walk them. We want to, tell them drink fluids. Always make sure that their water bottles are full, and this will help prevent, and a high fiber diet will help prevent constipation. So here's a little more specifics on the lochia. So all these cells are part of what lochia is. In the first days postpartum, usually the first 3 or 4 days, The lochia is termed lochia rubra. It is red. And then somewhere after that, up to day 10 to 14, she'll have what's called lochia serosa. So that's where it stops being so red and bloody looking. It's pinkish, maybe even brown. And then after a couple weeks and up to about 3 to 6 weeks, her lochia will now be what's termed lochia alba. So it's a whitish, yellowish looking substance. And breastfeeding women, usually about 3 weeks and they're done. Or it could take up to 6 weeks, especially if she's not breastfeeding, for her to still be having lochia. Okay. We instruct them that it should not have an odor other than what would be typical with menstruation. If it is something not typical of menstruation and it's foul smelling, then that is indicative of infection. And, she could have fever, chills, be achy. She needs to get in, and that needs to be addressed. And then, of course, we document the amount of lochia. So terms that we use for the amount of lochia is scant, small, moderate, or heavy. This takes some experience, learning, seeing pads in your daily practice to kind of determine what these look like or what this amount is. Moderate, we really don't want anybody having heavy flow. Maybe within the first hour you might see heavy flow. Moderate flow is we are changing pad. She's filling a pad in about 2 hours. A small flow is, she's needing to change her pad every 4 hours, and scant flow is like she could probably keep that pad all day without changing it. However, just for cleanliness and stuff, I just tell my women every time you get up to pee, change your pad. Okay. The episiotomy, so we went over this. The topicals are just creams that we put on their pad that are soothing. They can do sitz baths. And we used to provide them with a little sitz bath container. It looks like a big bedpan, but it's just round. And it has holes in the top edge. And then they have this bag of fluid with a tube that goes through these holes. And she can hang the bag high. She can fill it with warm water. It could be sudsy if she wants. And then she puts this tube in those holes and then opens it up, and then it just kind of just bathes over her perineum. We don't use those anymore. We just say, go soak in a warm, shallow tub. Don't go in there and bathe and get all dirty water soaking your tub, but you could go into a warm tub and just soak. That's okay. And then they can use hot packs, but typically these gals, they like the ice packs for at least the first 24 hours. We're going to be assessing pain just like we would assess pain with any patient. We determine the source, which is usually abdominal cramping. Maybe it's her back or her perineum. We, the type of pain, the duration, your Socrates assessment. We can give Tylenol and ibuprofen or narcotics. Ibuprofen is the drug of choice. And then, again, warm soaks. Okay. Assessing for DVTs. So we did review that when we talked about bubble heat. And then emotional status. So I'm not going to spend a lot of time on this, but so, they can have a wide range of emotions. They could be tearful. They could be joyful. They could be... These women can even be sad, especially after they go home. They're tired. They're exhausted. They've got to adjust to a new lifestyle, the parenting role. All kinds of emotions go into that. We really need to give support to these women and educate them on postpartum blues and postpartum depression and postpartum psychosis, which is... well, I think I have some slides that differentiate these, but postpartum blues is just, they're doing fine, they don't need medicated, they cry at puppy dog food commercials or whatever, just tearfulness. at simple little things, and it's all good. Okay, postpartum depression, they really start having struggles with, sometimes maybe even with activities of daily living. They're so exhausted. They don't like how the life is going. They can't keep up with anything. Their house is a mess. The baby's crying all the time. They don't know how to take care of the baby. They feel incompetent. And sometimes they need a little medical help, or maybe some strong support. But postpartum psychosis is a scary thing. These women have all kinds of different symptoms. They need medicated. They may even need hospitalized. Okay, so all right. So what goes on with a woman's body systems after delivery? So we need to have this decrease in blood volume because she produced this extra blood volume to support the pregnancy. So, which is one of the reasons why we do want her to diurese or pee. So we are really always asking her about voiding, but blood loss. So a woman with a postpartum hemorrhage can lose a lot of blood. And be considered to be having a hemorrhage before she has significant signs and symptoms, because she has so much blood volume to lose to begin with. So these women, sometimes it's like they're fine. We're addressing this postpartum hemorrhage, and then all of a sudden this woman is like doing really bad. She's passing out. Her vital signs are decompensating. So it can go quite quickly. And then so when they start losing a lot of this blood volume or plasma, we will see a rise in her hematocrit. Remember, the hematocrit is the percentage of red blood cells to the volume of blood. So we could be seeing that go up just because of losing a lot of that fluid. The white blood cell count can be a little bit elevated just because of the stress of the delivery. Fibrinogen is going to be increased because the body is wanting to protect her from a postpartum hemorrhage, which adds again to her risk of DVT. So we want to watch those closely. Hormone changes with pregnancy. So her estrogen and progesterone levels start dropping, and then that signals the anterior pituitary to start producing prolactin, which is what's needed for lactation. Okay, and then when there's no lactation that occurs, then the prolactin returns to normal. Okay, in about 3 to 4 weeks. Placental lactogen, cortisol, growth hormones, and insulinase levels decrease after delivery. And that's when we see a decrease in insulin needs, even for the diabetic mother, not just the gestational diabetic mother, but the diabetic mother. So they call that the honeymoon phase. So their insulin levels, or their insulin needs, decrease. So if this woman was gestational diabetic, or I'm sorry, if this woman was diabetic, she got pregnant, and then postpartum, she will see that her use of insulin is a lot less than it was previously. That's the honeymoon phase. Okay, so sleep patterns, of course, can you imagine? This is crazy thought that moms would be fatigued, so their sleep patterns are going to be all screwed up. They're going to be woken several times through the night. So we encourage these moms that during the day, when you put your baby down to rest a couple of times during those periods, you just go take a nap. Okay, even if it's only for an hour, just go get some rest. We need to, as far as the epidural is concerned, or spinal anesthesia, we need to make sure that she has her feeling and full function back of her legs, especially when she's trying to care for her baby. Headaches. So typically not a common thing just because a woman had a baby, but if she had a spinal, she may have what's called a post-dural puncture headache, and that is just because she has lost a little spinal fluid from that procedure of the spinal, and that causes them to have a headache. So if it's a post-dural puncture headache, So when she's laying down, she's feeling fine, and then all of a sudden you sit the head of her bed up, and she has excruciating sudden headache. So that's a post-dural headache. And I want to make sure I cover this with you, because I'm sure it was covered in the section on pain during labor. But to treat a post-dural headache is a blood patch. So we draw blood from the woman's anticube, and then we give it, the nurse draws it, sterile technique, hands it to the anesthesia, who is back there doing what seems to be an epidural, and he's just injecting that blood, like an auto transfusion type thing, into her spinal cord. Okay, so it helps with the volume, but it helps clot off that leak, and their headaches are like suddenly like gone. Okay, anyways, so sorry. Okay, so her renal system. So excuse me, I'm sorry. So her glomerular filtration rate, creatinine, BUN levels, those will all return to normal within a couple of months after delivery. Proteinuria, which she should not be having, but if she has preeclampsia and has proteinuria, then they should normalize after delivery. And we talked about, her huge diuresis. So her fluid and electrolyte balance can be a little wonky for a couple of weeks, and then usually that's returned to normal within 3 weeks after, once the diuresis and the intake and output kind of normalize. And again, output, the first couple of days, the output could reach up to 3,000 cc's a day. Respiratory system, so respiratory alkalosis, or compensated metabolic acidosis can occur during labor, and may persist for a couple of hours, but that usually returns to normal pretty quickly. A decrease in intra-abdominal pressure, just because, the intra-abdominal pressure from the size of the uterus, the birthing process, and then that intra-abdominal pressure is decreased, which takes pressure off her breathing. Okay, so that will all kind of return to normal within a couple of weeks. Because of the hormone changes during pregnancy, they will return to normal, and then so the skin and hair changes that she may have seen during pregnancy will usually return to normal. Some may not. Some problems may linger slightly, or like stretch marks may fade, but not completely go away. Cardiovascular system, so after the baby is born, this says cardiovascular instability. So after the baby's born, after the placenta is gone, all that amniotic fluid is gone, we have still all this extra blood volume. So it's not really an instability, but that's what they term it here. It's just the way the pregnant woman's cardiovascular system works. Her stroke volume, her cardiac output and stroke volume were all higher than normal because of pregnancy. Those will return to normal levels within a couple of days. Okay, they will remain elevated for a couple of days, but then they return to normal. Usually by the end of the postpartum period, which is about 6 weeks. Okay. So another reason why we want to make sure that we're watching her diuresis is if she's not getting rid of that extra fluid, it's not there for a purpose anymore, feeding the placenta and uterus, then she's going to have extra blood volume that is going to put her in a compromised state. So where is that going to dump besides her periphery? In her lungs. So we need to be listening to lung sounds on this woman to assess for peripheral edema. Pulmonary edema. I'm sorry. So her immune system, the white blood cell count, as I had said, is kind of increased during the labor process just because of the stress of labor. It usually returns to normal pretty quickly. immune system. So we do have ROGAM in here, RH immune globulin for any type of RH isoimmunization potentiality between mother and baby. So we would give ROGAM to prevent mom from creating antibodies. I'm not going to go into that whole lecture about ROGAM in this recording, but I know that the RH isoimmunization information is difficult, and I would love to talk to you guys face to face about that, because it is kind of a little difficult to wrap your brain around. Okay, so we can go over that again. If she's rubella non-immune, we will vaccinate her before discharge. Okay. Varicella vaccinations, so chickenpox may need to be done. Usually, this is kind of rare. It doesn't occur often. Okay, her tetanus, her Tdap, pertetanus, diphtheria, pertussis vaccinations. Most pregnant women get these prenatally. So we always check at admission if she had it. If she does not, then we make sure we vaccinate her before discharge. And then we also even suggest that dad get vaccinated. And this is, of course, protection for them, of course. But the pertussis, a baby getting pertussis is really bad. So we want all the people who are caring for this baby to be vaccinated to prevent for themselves, but to also protect a baby from getting pertussis. Anyways, the reproductive system, we've talked about involution of the uterus. We talked about the exfoliation process of the healing of the placenta. Vaginal changes, so depending on how bruised or edematous she got, if she has lacerations, all that healing will need to take place. However, okay, like it will never go back to, we always talk about going back to pre-pregnant size, which the vagina does not ever really return to pre-pregnant status, okay? Okay, so menstruation and ovulation. So non-lactating women or women who are not breastfeeding, so their menstruation, normal menstruation and ovulation, normal menstruation usually occurs within 6 to 8 weeks. And the first cycle, she may ovulate, she may not. Okay, lactating women can delay ovulation and menstruation for up to 3 months or more, depending on breastfeeding. So, and this is not foolproof. Okay. It is very good, but it's not foolproof. So if the woman is breastfeeding 100% of the time, she can almost rely on not ovulating, okay? But especially when baby starts getting introduced to other foods and baby is not breastfeeding as totally as she was before, then that and ovulation is very iffy. So we do educate these women about contraception just to be 100% or 99.9% sure. Okay. GI, okay, I'm not going to spend a lot of time here, but so, we just want to get this woman's gut getting back to normal, okay? So she's going to have a period of decreased motility, decreased tone. She may have some distension and constipation before she has that first bowel movement. We do offer stool softeners to women who've had babies, and we educate them on other medications we can give them if she's having constipation. But walking, getting up and ambulating, lots of fluids will also do the trick. Okay, musculoskeletal system. So just going to kind of run through this. So they just had a baby, and with the relaxin and progesterone, which are relaxants, those tissues are all relaxed, so she can actually have some, achingness from that. Abdominal muscles, can you guys imagine, are stretchy and flabby and weak. I'll use the wrong weak word, but sorry. Diastasis recti is just it's when the abdominal muscles centrally or midline separate. They can go back to normal, or she may always know that she has that little space in there. It's not a really big, huge issue, but she can still do sit-ups. She can still have a good abdominal physique if she wants it. So it's not a big, hairy deal. It's just sometimes something that happens. We've got to pay attention to cultural issues. There's different practices with different cultures. If you're not aware of them, just ask your patient, okay? And then try to do what you can to accommodate, okay? Oh my goodness. So ambulation, early ambulation. Women can do Kegel exercises. They're coming, so great if you want to do them, great if you don't. But they can, to help kind of increase that pelvic structure, or support that pelvic structure and get it back into shape. Frequent rest periods, get adequate rest, nutrition. So immediately, they could lose 10 to 12 pounds, which is the baby placenta and amniotic fluid, and then up to 5 pounds additionally within that first week because of all her diuresis. We want to assess good diet, prenatal vitamins. We've talked about elimination. We will instruct her about perineal care and let her know about infection. Teach her about good hygiene, which is, we have these squirt bottles, so when they get up and void, they can squirt their perineum with warm water and pat their perineum dry, or wipe front to back. We tell them to pat if they have stitches, okay? Frequent hand washing, no tampons, and and then ice packs to reduce pain and edema. There's this says apply for 20 minutes every 2 to 4 hours. Okay, so that's your test question. 20 minutes every 2 to 4 hours. Okay, for the first 24 hours. When you go in the hospital, we put these perineal pads on these women and they wear them. They just wear them, okay? They don't take them off after 20 minutes. Your test question, and I don't know that there's a test question. I just want you to know that if you have a test question, the ice packs are on for 20 minutes every 2 to 4 hours, okay? We've talked about after pains. So when oxytocin is released for breastfeeding, actually, it stimulates breastfeeding, but it also helps contract the uterus, okay? So she may be feeling these pains for a couple of days up to a week, and like I said, ibuprofen. I'm sorry. So women with HIV and AIDS, I didn't put any slides on here for this lecture. If you have any questions about that section, please let me know. Care of the post-surgical patient. So this is actually if a woman has a tubal ligation. So if she had a vaginal delivery, we usually schedule these tubals, before discharge, or we can wait and do them and have her come back at 6 weeks. If she has a C-section, well, they do it right when they're doing the C-section, okay? C-section birth is same assessments as a vaginal birth, okay? But she's on sips and chips until, just because she had surgery, she's on sips and chips until she feels like she is not vomiting. Some women have some nausea, vomiting issues after their C-section. We'll assess her incision if the dressing is off, and then get them ambulating as soon as possible. Usually by 6 hours, I like to at least have my woman standing at the bedside. If she feels able, like, to walk to the bathroom and back and sit on the toilet and kind of do a nice cleanup, and then as you know, maybe try to sit up in the chair and have a meal. Okay. But we need to make sure that when we stand up, she doesn't have any type of orthostatic hypotension type stuff. We can pre-medicate her like an hour before, to help with the incision pain when she stands up. Now, we instruct C-section women to splint their incision. We just take a folded up blanket, have her hold that over her incision and press firmly into her incision. Take a deep breath and cough. Okay, so she's a surgical patient. We want to keep her lungs from developing any fluid, pulmonary edema, or keep those lower airways open. Okay, so we have her cough and deep breathe. So infant nutrition. So here's your feeding choices. Breastfeeding. Here's your benefits for mom. You can look over those. Those are really great, and those can extend depending on her length of breastfeeding. Like if she breastfeeds for 3 months or 9 months, her benefits are according to how long she breastfeeds. So if she breastfeeds for 3 months, her benefits are not as substantial as they were if she breastfed for 9 to 12 months. There's your benefits for baby, and those extend beyond the infancy. So contraindications for breastfeeding: infants with galactosemia, mothers with TB, active TB, HIV, or herpes on the nipples, and depending on what medications she's taking, she may not be able to breastfeed. So this, we're going to review breast structure again. So the alveoli are just the little sacs or cells that produce the milk. A cluster of those alveoli are in the lobes or lobules. The ductals are the little tiny ducts that come from each one of those lobules, and then those ductals empty into the big ducts that drain into the nipple. Okay, you know about the areola, Montgomery tubercles, and then the basic physiology of the breast. Okay, so lactogenesis is the term for milk production and secretion, and because of a decrease in the estrogen and progesterone, remember that stimulates the anterior pituitary gland to secrete prolactin. Prolactin stimulates the alveoli to secrete milk. Okay. And then when we get nipple stimulation, that triggers the release of oxytocin from the posterior pituitary, and the oxytocin contracts the smooth muscles of the alveoli to eject the milk out, and then into the ducts. Okay, so nipple stimulation is the baby at the breast. Okay, so we want the baby at the breast as often as possible. Now, the milk ejection reflex or letdown reflex, some women feel this, some women don't. It feels like a tingling sensation, but there's nothing wrong with this. There's nothing good with this. It's just sometimes women feel it, sometimes they don't. Okay, formula feeding. So, all right, okay. So, formula feeding. Every 3 to 4 hours, less 15 cc's or less, usually 5 to 10 to start out the first couple of days. There's all the different types: ready to feed, concentrated, or powdered. Ready to feed is you just pour it right out of the container and feed it to your baby. Concentrated is you pour it out of the container and mix it with water to dilute it, and then the powdered is powdered formula that you mix with water. And if you can remember from Peggy's talk on formula feeding, like, oh gosh, it could be, so if they can buy ready to feed, if they can afford it, then that would probably be their best option. But there is concern about the powdered. Okay, so feed babies upright, no propping bottles. So we just instruct them about, I don't even instruct them about all the different type of bottles. I just try a couple different kinds. They're all great. Go for it. Okay. So breastfeeding, I'm going to just run through this really quickly because of our time with Peggy. So we want baby skin to skin at the chest or on the breast. Okay, that stimulates both mom and babe. Mom can see baby's feeding cues; they're listed there. We want to make sure that babies have proper latch. Nose tip to nipple tip, belly to belly. The baby extends their neck and opens their mouth to get the nipple in. We want them on the areola, not the nipple. Their lips are flanged out like a tulip. Um, um, and then just instructing mom on these sucking patterns. So baby sucks really fast at first, and then slows down and has these long draws, deeper, and we can hear the swallowing. We can review these positions during clinicals, but the cradle hold is the way everybody holds a baby initially. Cross cradle, I think Peggy showed you that. I will need to demonstrate these for you, but I think the book shows them as well. We want moms to be comfortable. We don't want mom to take the breast to the baby. We want mom to take the baby to the breast. Okay. So here is kind of the sucking ratio. Kind of similar to this ratio of signs of successful breastfeeding. After breastfeeding, babies are in what seems to be a really euphoric, relaxed state. We weigh the babies daily. They can lose 5 to 7% weight loss. Actually, they can lose up to 10%. So at 10%, that's when we call the docs and say, hey, baby lost 10%. We get lactation in there. We might be doing some different things to help support baby because more than 10% is too much. Ineffective feeding. So, baby doesn't breastfeed for very long, or baby's not having a good suck-swallow ratio. Incorrect latch, baby's not getting good. If baby has an incorrect latch, not only is she traumatizing mom's nipple, she's not getting good feeds, okay? Breast engorgement, where mom's milk comes in and her breasts are so engorged and full that it's too hard for baby to latch on. So we will do warm compresses before a feed to help dilate everything. We might even express a little bit of milk to soften it up a little bit. We might even massage a little bit. We will breastfeed baby, and then after the feeding we will put cold on. That will kind of constrict everything to just decrease the filling so she doesn't get so engorged. Okay, well-fitting bras. Expressing breast milk. So here is you can read this slide. Here is kind of what we instruct moms on when they collect milk, what kind of the storage protocols are for sitting on the counter, in the fridge, in the freezer, okay? How to thaw it. Now weaning babies, so there's gradual weaning, which we recommend. I mean, you can wean your baby. You can one day wake up and say, you're done. That's going to be pretty traumatic on both mom and babe because mom's going to get engorged and have a lot of pain, and baby's going to fight whatever. Baby's going to want to breastfeed. So even though you're giving her a bottle, even though it has breast milk in it, it might be more difficult. Baby might not be happy with that. So we do suggest a gradual feeding where she eliminates one feed for a few days and then adds another feed for a few days until baby is completely weaned. Bonding, I'm not going to lecture on this. Please do look over this because I do feel like there's a couple of questions on bonding and these different phases, what moms go through. So I'm going to let you kind of read over those. Emotional events, so you can read over this about baby blues, postpartum depression, and postpartum psychosis, okay? Discharge planning, so we teach mom about these things, okay? So how to care for herself after she goes home. We teach her about getting an adequate rest, what normal weight loss is, We tell them not to exercise before 6 weeks unless it's just simple walking, pain management, all those things, contraception, okay? So special considerations for adolescent mothers, older mothers, and women who are placing their infants for adoption, and or mothers who are having their babies removed from their care. So we need to know about community resources to hook our patients up with. Okay, so that was chapter 15. Please let me know if you have any questions. I'm just checking my time here. Okay, so an hour and 10 minutes, so we've got good time here, because this one's only 20 slides. It's chapter 16, caring for the woman who has complications. Here are your learning outcomes. So postpartum hemorrhage. We've talked about postpartum hemorrhage. What is postpartum hemorrhage? Well, to be classified as postpartum hemorrhage is if your blood loss is greater than 500 cc's after a vaginal delivery, or greater than 1,000 cc's after a C-section delivery. And I do believe there might be some texts that say if this is your second C-section, you can have up to 1,500 cc's. If your hematocrit decreases 10%, or if you, and then if you require a blood transfusion, you had a postpartum hemorrhage, okay? So we need to accurately assess blood loss. Now, we don't, how do you know she had 500 cc's of blood loss? Well, we estimate, visual estimation, and we go through competencies and drills and practices about what 100 cc's looks like on a pad, what 500 cc's looks like on the bed, okay? So it's just kind of subjective visual estimate. But if we kind of get the feeling like this is a little too much blood, then we do need to start weighing pads. And ouch, we have dry weights for every pad that we put under a woman in OB. And so what we do is we take the soaked pad, we put it on a scale and we weigh it. And the scale will tell us grams, how many grams it is. And then so we take that amount, so say it was 200 grams, and the pad that we used was only 20 grams. Well, she had 180 cc blood loss. 1 gram equals 1 cc. So they call postpartum hemorrhage either early or late or primary or secondary. Early or primary is within the first 24 hours, and then anything after 24 hours is called the late or secondary. Okay. Keep in mind a little fact here that you might want to remember is there are up to about 500 cc's of blood flowing through the uterus every minute. Okay? So every minute she has 500 cc's flowing through her uterus. So just imagine how that can add up very quickly over 5 minutes, okay? So when there's a thing called the 4 T's that will give us a clue about the possibility of a postpartum hemorrhage. Those 4 T's are: 1, tone. Is her uterus firm or boggy? Does she have a full bladder? Okay, that's tone. Trauma is, did she have any lacerations or does she have any hematomas that are bleeding? Tissue, does she have any retained placental tissue or any retained clots in her uterus? And then thrombin, the last one, is does she have a coagulopathy problem? All right, so uterine atony is the most common cause of postpartum hemorrhage. In other words, the uterus does not contract. That's the most common cause, okay? Trauma could be anything from uterine, oh my goodness. Okay, so trauma, like she has a laceration somewhere in her perineum or vagina, what you'll see is bleeding, but the uterus is firm in midline. So you can maybe say that she's not bleeding from her uterus if it's firm in midline, okay? That the bleeding is coming from that trauma, okay? So if she has tissue, in other words, placenta, then the physician, when the placenta is delivered, the physician assesses that placenta to determine, is all of it here? And sometimes they miss stuff, and sometimes placental tissue is retained. So we can see bleeding from that, okay? And then sometimes their bleeding is okay in the first 24 hours and even okay in 48 hours. But then we send them home and they keep bleeding a lot, and that adds up. And then they end up with a secondary or late hemorrhage at home because of retained placenta. Okay? And then the thrombin issue usually presents late, so they go into HELP syndrome. You can review that from the previous sections, previous lectures. DIC, she could have a coagulation problem unrelated to pregnancy that is causing a complication. All right. So the late postpartum hemorrhage is after 24 hours, but usually occurs within the first 2 weeks. Retained placenta, again, is the most common cause. Subinvolution, so the uterus is not healing and contracting and returning to pre-pregnant size correctly. So what do? We give Methergin, actually, or Cytotec, Cytotec, to help with the contractility of the uterus. We may need to give antibiotics, and occasionally we do take women back for a D&C, dilation and curettage. So we dilate their cervix, we go in with a little curette thing and scrape out the fragments that are left in there. Okay, we educate mom on what those signs and symptoms are. Okay, and then hypovolemic shock. So this woman has had a serious postpartum hemorrhage where she's going into shock. These are your signs and symptoms for shock. So that's why we do our frequent vital signs and medical management, especially in the early our primary postpartum hemorrhages. Is oxytocin is our first line. So we hang a bag of oxytocin. It's a 30-unit. It's a 500 cc bag with 30 units of pitocin in it. That's what we use at CMC, and actually that's what they use at St. Pat's, I think, as well. But some facilities may have different concentrations. And then we can run that. We can run that postpartum oxytocin at 999 cc's per hour. So that's just basically running that bag in a half an hour, okay? Or we can give her a dose of Pitocin IM. So maybe she doesn't have an IV site, maybe for whatever reason. So we have 10-unit vials of Pitocin, and we can give that IM. And then Cytotec is our next drug. It is a 600 to 800 microgram tablet that we give rectally. Usually we will give those rectally, but sometimes we will give those orally as well. Methergin is another drug we will use, 0.2 milligrams IM. We can give that every 2 hours, or we can give a PO dose, which we usually don't do. We usually just give the IM dose. And then Hemobate is the last one we will try, 0.25 milligrams IM or intrauterine. So they go right through the abdominal wall. So they don't stick it up in her vagina. They go right through her abdominal wall into the uterus. Okay, but usually we just give it IM. Okay. We can do lab tests if she's having a hemorrhage. These are the lab studies we would do. We got to have accurate INO. So an indwelling catheter is usually going in. We might need to supply mom with oxygen. We can give an IV fluid bolus, and hopefully that takes care of it. But if she's having H&H issues, dropping her H&H, we might need to do blood replacement products. Okay. And then pain management, because we've probably been rubbing her fundus continuously for hours and hours and hours. Okay. Hematomas. Okay, so hematoma is basically a bruise But hematomas can develop in a perineum, and she can have massive blood loss in her perineum. So hematoma, your uterus is firm, you have normal vaginal bleeding, okay, but she has unrelenting perineal pain or rectal pain, okay. It may look bluish, it may look a blue purplish color. Her vulva looks like it's bulging or full. It's painful to the touch, and she's not able to void because it's blocking her urethra. Okay, she can have a huge postpartum hemorrhage just from a hematoma. Okay, so usually those do require a surgical intervention. Okay, and of course pain management. Thrombophlebitis and thrombosis. Here are those definitions. So again. Postpartum women are at increased risk for this. They call it the Virchow's triad. So postpartum women are in a hypercoagulable state. They have venous stasis, one because of a pregnant uterus decreasing venous return, and then vein injury because of that. Okay, so anyways. Here are all the things that can contribute to thrombosis and thrombophlebitis. Signs and symptoms could not have any. Or if you're checking calves, she may have some calf signs and symptoms that are listed here. Okay. So diagnostic tests like do not do a Homans, palpate and visually observe her calves. They can do a D-dimer blood test. They can do Doppler studies or an ultrasound to actually visualize the clot. I've never seen an MRI or perfusion scan or any of these kind of things, but that's all fancy stuff above my head. Anyways, so what do we do? So, of course, we're going to give analgesics. Of course, rest, elevate the extremity. We don't usually put compression stockings or SCD device on vaginal deliveries, but if she has a risk or has a problem, we will, but we do absolutely put the SCDs on C-section deliveries. Okay, increased fluids, moist compresses, and anticoagulant therapy. Okay, so heparin or Lovenox or Coumadin can be given postpartum, and then monitor for bleeding and bruising. If she has a big old clot or something like that we're watching in her leg, we might even do leg circumferences. Okay, so a complication of those is a pulmonary embolus, where the clot travels to her lungs. Okay, here's her signs and symptoms: chest pain. She might have, she might have a respiratory collapse. Okay, IV, oxygenate, put her on a cardiac monitor, continuous pulse ox, automatic BP, and then medical interventions as needed. Okay, puerperal infections. Okay, so these are infections that happen within the first 28 days of delivery. Puerperal infections. Okay. Endometriosis, so she has a uterine infection, mastitis, an infection in the breast. The signs and symptoms of both of those are listed there. Antibiotics are the treatment for both. Okay, antipyretics if she has fevers, fluid hydration, analgesics for pain. If she has a C-section wound, so here's your signs and symptoms for an infection in the wound. So she'll need antibiotics to treat that, maybe even surgical drainage. She may get a urinary tract infection, so there's your signs and symptoms for that. Antibiotics. Okay. Postpartum blues. So postpartum blues really don't need no treatment. Here are your signs and symptoms for those. This will resolve. Postpartum depression. Here are your signs and symptoms for those, and she may need medical treatment. She may need just psychological counseling or extra support, and that will improve. And then psychosis. So this is really bad stuff. Here's your risk factors, pre-existing problems. They have a psychosis, so they have hallucinations, they hear voices, they could be suicidal, they could be homicidal, they need hospitalization, okay, and strong psychotic medications. So we just teach them, to ask for help, support help, okay, and to call their physician, because they might just need some counseling therapy, or they might need some medications for postpartum depression. Here are those medications that they may try. Lots of rest, lots of support, and community resources. I'm not going to go over vulnerable populations, but these are an issue for people who have babies. We get them hooked up with social services, okay? All right. So that's the end of last week's lecture, okay? I'm going to take a little break. I'm going to get this posted, and then later today I will put this week's lecture on Moodle as well. I do want you guys to let me know about the exam this weekend. It's on the content I just lectured on, and also the content that I will be putting a lecture on. So if you feel comfortable with that information, let's go ahead and take the test this weekend as scheduled. If you do not, then I need you guys to let me know. Okay? Thank you.